Hello friends and welcome back to Malik Helps. Let's continue our esophagus now. Hope you enjoyed the day today and some days with your friends in person. So let's get back to our esophagus, and in this week we will try our best to complete the esophagus. After enjoying the weekend, you can move to the next part with me in the next week. So let's just try our best to watch the videos on 2x or howsoever you like it whenever you want to spend some 15 minutes on my channel. So let's start with this part. In this part, we will be learning about the Zenker's diverticulum with images, with x-rays, everything will be included. Zenker's diverticulum and motility disorders of our esophagus and the acid reflux GERD. So let's start. Here we go with the diagram first of all. That this is a photo showing Zenker's diverticulum. This is the neck portion. Just so you know where exactly is the Zenker's diverticulum present, it's in the neck portion. And to be honest, the problem in Zenker's diverticulum, it's not really related to the esophagus. If we technically speak about it, it's more like a problem related to the pharynx exactly. So Zenker's diverticulum, how to call it with the other name? Pharyngeal pouch, simply. So, and next is the anatomy about it. That anatomy is simply the problem is with the inferior constrictor muscles. This is something known as Cleon's triangle. I'll let you know with my own diagram in my notes soon. And just you know that this is how the anatomical diagram will look like. And inferior constrictor muscles are involved in the outpouching of the pharyngeal pouch or Zenker's diverticulum. So let's see one by one what are the problems. So first of all, let's see what is true diverticulum and what is false diverticulum. So diverticulum is when the outpouching is involving all the layers, that is serosa, mucosa, muscularis, and you know about it. So when all layers are involved, that is a true diverticulum. If only the mucosa is outpouched, that is a false diverticulum. Since false diverticulum is due to increased pressure, so we also call it punction diverticulum. The name is important, remember, it has been asked in some exam. I have seen the question. So when the increased pressure causes some outpouching, that is also known as punction diverticulum. So Zenker's diverticulum is basically the false diverticulum. Let's recap it whatever we have seen in just now. So inferior constrictor muscles, here is our diagram. So inferior constrictor muscles have on the top part there is thyropharyngeus, and in the below part there is cricopharyngeal sphincter. We have talked about the anatomy of esophageal sphincter. So just this is the diagram, and between both of these inferior constrictor muscles there is a small space which is weak actually, and this weak space is known as Cleon's dehiscence. So Cleon's dehiscence what exactly causes the outpouching, and this is the weak point, that's why it causes the outpouching. If you can see this neon color, so this is how I marked in my notebook that this is Zenker's diverticulum. Through this Cleon's dehiscence, it will get outpouched, and below cricopharyngeal sphincter, what is there? So there is internal circular fibers of esophagus in the anatomical portion, and below the internal circular fibers of esophagus there are some outer longitudinal fibers of esophagus. So what happens exactly is, since the false diverticulum is due to increased pressure, we also call it punction diverticulum. But what is Zenker's diverticulum exactly? What causes it exactly? So it's a cricopharyngeal diverticulum. You know about the sphincter of esophagus, that there is a cricopharyngeal diverticulum present over there. Once there is too much increase in pressure in the cricopharyngeal diverticulum, only mucosa gets to be outpouched, which we known as the mucosal diverticulum, or let's say Zenker's diverticulum or false diverticulum. Here is written that inferior constrictor muscles has two fibers. One is thyropharyngeus and second is cricopharyngeus. So outpouching between the two layers of the muscle inferior constrictor mucosa of pharynx, outpouch is false or punction diverticulum. The word may be written wrong here, pulsion. This is what? Punction diverticulum. So the outpouching between the two layers of the muscle inferior constrictor, where it is This is the inferior constrictor muscle showing the two parts to you. So outpouching between the two layers of the muscle in inferior constrictor mucosa of pharynx, outpouches which result in the Zenker's diverticulum, false diverticulum, or the punctured diverticulum. How it happens exactly? So abnormal motility disorders such as inferior constrictor contracts, but sometimes it fails to relax exactly. So that failure of synchronized relaxation of cricopharyngeal sphincter results in this outpouching. Which outpouching? The Zenker's diverticulum. From where it will get out pouches? So Cleon's dehiscence is the weakest point here, from where only the mucosa can get the outpouching. So mucosal outpouching through the Cleon's dehiscence, Zenker's diverticulum, which is posterolateral diverticulum. How to see it, what the patient will complain exactly? The clinical features will be, first of all, it will be our elderly patient, or let's say the age 40 to 60 age group. So when they will go to bed, they will feel the regurgitation of the food, that the food is trying to come back in their mouth, something like this. And halitosis, bad smell, which is also known as bad smell. Bad smell equals to bad impression, we all know about it. So bad smell, why, sir, why bad smell? Because when there is food got stuck in this, you can see this neon, yeah. When the food gets stuck in this neon portion, which is Zenker's diverticulum, so the food is really got stuck in the throat, and it can stay in this outpouching for a longer time. So whenever the patient will be talking with someone, they can feel, others can feel the smell, because this food is not getting digested, and this food is just getting wasted. So so this food will cause the halitosis, or let's say the bad smell. So what the patient will complain exactly? Sir, the patient will say like, I can feel that the food is coming back to my mouth when I'm trying to sleep or trying to change the positions in the bed, and the others are feeling bad breath from him, which is halitosis. How to investigate the problem exactly? So upper GI endoscopy, this is the first line investigation program, that it may show the mouth of diverticulum, that where exactly the diverticulum has got diverted. And how to diagnose it? Barium swallow is, we can do barium swallow, but if the surgeon like to go with the CT when they are talking about the GI tract surgery. They like to go with the CT or with the oral contrast. The contrast, or the barium swallow, let's say, the contrast will get stuck into the Zenker's diverticulum. This is how the x-ray exactly looks like, that this is the neck portion, and this is the outpouching. So this outpouching is causing some problems for our patient, that it will the food from this will get regurgitated here, and it will cause bad breath for the patient, halitosis. So when we feel the contrast, so this is how the contrast gets stuck in the neck of the patient, or in the Zenker's diverticulum exactly, which is a false diverticulum. And we are gonna see it on the x-ray like this, if some surgeon decided to go with the x-ray. But remember, we will try to go with the CT. This is how the CT is gonna show the best way, that in surgeons like to go with the CT scan nowadays in the cases of GI tract surgery. So how you will diagnose it? Sir, we will investigate it through the upper GI endoscopy. It will show us the mouth of diverticulum, and how the diagnosis, which methods of investigation you're gonna use. The CT scan will be the best. However, you can also perform the barium swallow sometimes. How to treat Zenker's diverticulum now? So first of all, cut the diverticulum. Cut the septum. I will show you in a minute how to cut it. So cut the septum, which is creating this Zenker's diverticulum. So diverticulotomy, that we cut the diverticulum. This is diverticulotomy, plus cricopharyngeal muscle, which is causing the increase in pressure. Remember, the main cause of Zenker's diverticulum is simply the increase in pressure between the inferior constrictor muscle. muscles, and the main muscle which is involved is cricopharyngeal muscles. So cricopharyngeal muscle is causing increase in pressure, due to which the Zenker's diverticulum is getting outpouched, and from where it will get outpouched, we have seen the Cleon's dehiscence, which is type of a triangle weak point. So we are going to cut the diverticulum plus the cricopharyngeal muscle as well. So how to name the treatment? Diverticulotomy plus cricopharyngeal myotomy. So this is how the problem is going to be solved. But nowadays something else is also in the practice. So endoscopic diverticulectomy, that surgery has become a bit easier nowadays. It's not so invasive treatment nowadays. Endoscopic diverticulectomy, which is also known as Dolman's procedure. I'll show you the photo in a minute. And stapled diverticulopexy, this is the minimal invasive treatment nowadays which is going on, and we have good prognosis for the Zenker's diverticulum. So this is the photo showing Dolman's procedure. Important for us is to remember, for higher grade exams like FMGE, sometimes they directly like to ask what is Dolman's procedure and for what exactly it is used. So it's important to remember the name, that for the Zenker's diverticulum we use the Dolman's procedure. So here is the photo showing what exactly is to cut. So through our best procedure, what we will do is this is the below pink lane. The below is the Zenker's diverticulum, and above is the esophagus. So here in between, here forms a septum between both of them. So if we cut the septum, this is gonna solve our problem. The food is not going to get stored in this diverticulum anymore, and our patient is happy. Here is another photo showing the same thing, if you understand through the different perspective. That anterior portion, here is the esophagus, and the posterior portion, here is the Zenker's diverticulum. So what is Dolman's procedure? Simply cutting the septum between the esophagus and the Zenker's diverticulum. It is gonna solve the problem of our patient, and we have good prognosis for it. After the surgery, the patient is happy and living free. So also remember, recap about it: diverticulectomy plus cricopharyngeal myotomy. Let's go to our next part. Next part is the mobility disorders of the esophagus. So here are some MCQs which I have directly taken from the exam. That most common motility disorder when the examiner asks, that is Achalasia cardia, which is a hypomotility disorder. What is that? Achalasia cardia. I'll show you the photo in a minute. And most common hypermotility disorder, if the examiner asks, so that will be nutcracker. They also call it Jacquemer's esophagus. So I'm gonna explain you one by one what are them. And remember, this is the important portion for the examiners. The examiner love to ask some terminologies in this portion. So this is a photo showing achalasia. So where is the problem? The problem is in the lower esophageal sphincter, that it fails to relax. So if it fails to relax, this is going to cause some problem. One of the main problem is mega esophagus, that the food will not get be able to pass easily to the stomach, and it will get stuck somewhere in the lower below the or above the lower esophageal sphincter. So it's going to cause something new, esophageal dilation, or some people also call it mega esophagus. So this is how it's gonna look like. This is the another photo showing the same thing. Maybe people have different perspective of looking at the things. So this is how our dilated esophagus is going to look on the images. So achalasia is simply the lower esophageal sphincter fails to relax. This at normal stage it stays contracted. So when it fails to relax, it will cause some esophageal dilation, or we call it mega esophagus. And second thing, what will let us know that this is achalasia, this is ineffective peristalsis in the body of esophagus. So both of the things should be there. Please note that in achalasia, the lower esophageal sphincter will not relax, plus there is ineffective peristalsis in body of esophagus. So who will present this with the achalasia? So risk factor is the age group of 30 to 60 year of age people, and Chagas disease is also there. All groove syndrome is also there. We will study about these Chagas disease and all groove syndrome in another parts. For now, just know that risk factor is 30 to 60 years of age, Chagas disease and all groove syndrome. And so let's see how it occurs exactly. So first of all, we need to know that peristalsis requires a parasympathetic and vagal supply. So the parasympathetic supply will relax the sphincter, and opening of the sphincter also requires the parasympathetic supply and vagal supply. So what happens is that in some part of the esophagus, you can see the rough diagrammatic representation here. This is our esophagus, and the lower esophageal sphincter is this one, the marking red by. So what happens is, in some area of lower esophagus, the parasympathetic supply, or let's say the ganglions, are absent, or sometimes they are reduced too much. So this is how it happens, that due to absent parasympathetic ganglia in lower esophageal sphincter, the lower esophageal sphincter get failed to relax, and due to reduced ganglia in the body, the peristalsis is weak or ineffective. So when there is destruction, or when there is loss of mesenteric plexus, they are the ganglions which are supplying the esophagus or lower esophageal sphincter, and they help exactly in the peristalsis. So when there is destruction and loss of mesenteric plexus, it will result in the failure of lower esophageal sphincter to get relaxed. So lower esophageal sphincter, when tight or narrow, so what will happen is exactly is the food will get stuck in this region. As you can see, I tried to mention it in the diagram for you. This red circles, this is consider it as food. The food got stuck in the proximal esophagus, and it will dilate the esophagus, and as a result, the more severity, how to call it, mega esophagus. Some surgeons call it mega esophagus. So as a result, what can happen is, it can lead to esophagitis. There is nothing to be stopped in esophagus exactly. So it can cause the inflammation in esophagus, and it can also cause the squamous cell carcinoma risk. Actually, the patient sometimes do not really present in the initial stages. They come at late stages due to lack of care. They care about your body or not. So they come at late stages, and when there is too much of food, or too much of irritation in the esophagus, it will already lead to the squamous cell carcinoma risk at high basis. So let's see how the patient will present exactly. So first of all, middle-aged female, this is the triad of achalasia. That dysphagia will be there, which will be initially for the liquid foods, and later will be the solid foods. Eventually it will be the problem for both of the food, liquid and solid, but at initial stages only liquids are hard to pass. But so in the initial stages, solid food somehow able to make it space to get past. But eventually what will happen is, the problem will be with the liquid and solid food, both of them, eventually at end stages or terminal stages. And secondly, as the food is not able to pass through the esophagus to the stomach, so what will happen is regurgitation of the food. The patient, if lie down while sleeping, he will feel the food is getting back to his throat or mouth, like that regurgitation. You all know about it. And as the vitamins and minerals or food is not passing to the stomach, hence to the intestine, and so on, is the absorption is not happening for the patient. And if the patient is coming at late stages already, so he might have already noticed some weight loss in himself, because if the nutrients and food will not pass to the intestine, there will be no absorption, and the person will see the weight loss. So and there is another in modern books, our new books, I have seen that there is Eckhart's score as well. No need to know a lot about it, just remember that the clinical features, the triad of achalasia plus the retrosternal pain. So this is what known as Eckhart's score. So dysphagia, regurgitation, retrosternal pain or heartburn plus weight loss, and this is the Eckhart's score. But remember about the triad as well. That triad is dysphagia, regurgitation and weight loss. So how to investigate it? Sir, please do upper GI endoscopy at the first place. This is the most thing which surgeons prefer nowadays, that if any problem is related to esophagus is there, they try to go with the esophageal endoscopy first of all. We can also take a biopsy while doing this, so that we can rule out the malignancy already. And if there is any kind of mechanical obstruction, we can also rule out it already. But if we talk about the investigation of choice, the investigation of choice is esophageal manometry. Let's see what it is. So this is how the esophageal manometry looks like. Please do not get scared through the diagram. I'll tell you what exactly you need to know. So first of all, note that the examiner can give you this image directly, and do not mention what is this, why this is, and they can ask directly that name it, what it is exactly. So and also note that I have taken a clear image for you, but maybe in the exam the image is not clear exactly, and maybe in the exam the image is black and white. So we never gonna know what the examiner will twist for us and what's waiting for us. But just so you know, we can so esophageal manometry basically measures the pressure. So this is where exactly you can note that maybe it can be blur in the exam as well. You can see a little bit that this is a pressure reading. MMHG is what? A pressure reading. So after the esophageal manometry, so we come to know about the findings of the what type of pressure exactly is this. The pressure will help us in diagnosing how severe is the grade exactly. So and what is to be done in esophageal manometry, that a manometer is a device which will be inserted to the low till the lower esophageal sphincter, and this is going to help us in order to measure the pressure findings. This is how the manometry results will look like, and this is what how to do it. So lubricate the catheter, insert it through the nose and guide down to the stomach. Catheter taped in the place while you lie on some side, and the doctor measures the lower esophageal sphincter as you swallow the sips of water. So when you will take the sip of water, it is going to pass to your stomach, yeah. So the device or the manometer will be able to help the doctor or help the surgeon in order to understand how much pressure is over there. What to do with the investigations of the achalasia? First of all, try to go with the upper GI endoscopy. It will be the first thing we must do. Second, we can do the esophageal manometry to confirm the diagnosis. And they gave some the modern books gave some Chicago classification, which is a manometric classification of achalasia. Let's see it in short. It's not a very big science to remember about it. It's simply three types. Type 1 is classic, which is in which 100% peristalsis is absent, and there is a high resting pressure of the lower esophageal sphincter. Remember what we need to see for achalasia. We need to see the lower esophageal sphincter failure to relax, and we need to see the ineffective peristalsis in the body of esophagus. So what we need to see in type 1 of Chicago classification, which is a manometric classification of achalasia, type 1 will be classic, 100% peristalsis is absent over there, plus the high resting pressure of the lower esophageal sphincter. In type 2, what we will see is pan-esophageal pressurization in most more than 20 swallows, 20% of swallows. Sir, what is this pan-esophageal pressurization? So sir, simply understand it what it is, that in all the esophagus there is a high pressure. In type 1 there is a lower esophageal pressure only, but in the type 2, in all the esophagus the pressure will be very high. In type 3 we will see just the spasm. So this is the easy classification of Chicago's classification. Now let's see what are some other ways of making the diagnosis for the achalasia. So remember, first of all, this is the old method. Some surgeons also use it nowadays, but only if the manometer is not available at the hospital. So remember that investigation of the first thing you will do is endoscopy. The investigation of choice will be esophageal manometry, but if nothing is available at the hospital, try to go with the barium swallow. So in barium swallow, what we do is simply we inject or ask the patient to swallow the contrast, and we will come to know through the x-ray how the things got stuck in the, or the contrast got stuck in the esophagus. So I'll show you the x-ray as well, but first let's see barium swallow. This is simply, there is something to note here, that there can be two versions after barium swallow which are causing problem for our patient. That there can be the lower esophageal sphincter narrowing, and there can be carcinoma of esophagus. So first let's see the diagram, that this is the rough estimation of barium swallow, bird beak we call it, that the lower esophageal sphincter will look narrow over there, which is a smooth tapering. We call it smooth tapering, that you see the red arrows, this is something known as smooth tapering, that it is smoothly getting narrows towards the lower esophageal sphincter. But in carcinoma, what happens is that this is not smooth, this is something in the middle of the esophagus first of all. So how we call it nowadays, we call it abrupt type of narrowing. So let's read the text with me, that when the patient is asked to swallow the barium, so it can we can find bird beak, we call it bird beak, we call it rat tail. So this is basically lower esophageal narrowing with the smooth tapering. Understand smooth tapering? Let me know in comments if you don't. So this is achalasia exactly. And in the cases of carcinoma of esophagus, because carcinoma can also happen if the esophagus is irritated by the food for a longer time and the patient is not aware about going to the doctor or surgeon. So carcinoma of esophagus will be the narrowing in the middle somewhere, not exactly in the lower part, and the narrowing is abrupt like this. This is very sharp or abrupt narrowing as we call it. Hope you understood it. Here is a photo showing achalasia, that the patient has swallowed the barium contrast, and it got stuck in the, it shows the narrowing which is with the smooth tapering. So this is the x-ray showing the narrowing of the lower esophageal sphincter, which is with the smooth tapering, and we call it what, bird beak or rat tail. You can see here that this lower esophageal sphincter got narrowed here, and the contrast shows the dilation of the esophagus as well. And this is a photo showing the carcinoma of esophagus, that this is with the abrupt narrowing, and this is somewhere in the middle of the esophagus. So this is how we come to know, or we can guess that if this is achalasia or this is the carcinoma of esophagus. So carcinoma of esophagus is more probably found in the middle with the abrupt narrowing of the esophagus, And barium swallow, we see the bird beak, or some surgeons call it rat tail as well. So this is how the x-ray is going to be. Let's see how to treat this condition now. So first of all, I want you to remember that not all the surgical pathologies are requiring surgery exactly. So we can ask it from the patient that from his symptoms we can understand that it's initial stage or it's the late stage. So first of all, we will try to go with the medical management, which will be some pills or some drugs. And if the problem is not getting solved with the drugs, we will try to go with the surgery. So first we can do is medical management, and then we can go with the minimal invasive surgery. And if nothing is the best for the patient, the last option is surgery. We have to go with that. So in medical management, we can prescribe the patient calcium channel blockers. They will help the lower esophageal sphincter to relax a bit. And remember, this we can do this when the patient came to us in the early stages. If the stages is in somewhere middle, from the early to the late, so we can go with the minimal invasive surgery. We can inject botox, we can do endoscopic dilation of lower esophageal sphincter. And the treatment of choice now, exactly, because we are studying surgery, so our medical management, if got failed, or if the minimal invasive procedure got failed, so what we are going to do next is we will go with the treatment of choice, which is surgery. And the treatment of choice for achalasia is Heller's cardiomyotomy, and the second is POEM. So I'll let you know why it is cardiomyotomy. So first of all, we'll talk about the Heller's cardiomyotomy, in which what we do is that we try to this is the cardia part, upper part of the stomach. That's why this is in the name of the treatment as well, that this is the upper part. The cardia part of the stomach is here near to the lower esophageal sphincter. And we try to cut the muscle of the lower esophageal sphincter, because there is a narrowing. If we cut some muscles from there, then our problem can be solved. So we are going to cut it, but we don't cut the mucosa in this part. Remember that why we don't cut in the mucosa in this part? There is a risk of perforation. That's why we try not to cut or not to touch the mucosa here. So this is simply the Heller's cardiomyotomy. Now understand one more thing here is that if we cut some muscles of the lower esophageal sphincter, now the acid can also flow back here. Yeah. So if we try to cut this some muscles by keeping the mucosa intact in the lower esophageal sphincter, we are giving the patient GERD for free. Now we have another problem. We treated one problem, and now we have another problem. So remember that whenever we are doing Heller's cardiomyotomy, we always add some anti-reflux procedure. We will see very well what are some anti-reflux procedure. Just for you now, you should know that in Heller's cardiomyotomy, we also add some anti-reflux procedure, because if we will cut some muscles of the lower esophageal sphincter, the acid will flow back as well. So we need to do this solution for the patient. We need to include the anti-reflux procedure. So let's see the second treatment, which is per oral endoscopic myotomy. Sometimes the examiner directly say POEM. So this is the myotomy from the inside by the endoscope from the mouth. We insert an endoscope from the mouth, and this time we are cutting the muscles from the inside actually. So this is the only difference, that in Heller's cardiomyotomy we are cutting the muscles from outside, but in POEM we are cutting the muscles from inside. So now what we will do is myotomy from inside by endoscope from mouth. and serosa will be still intact, so we don't cut serosa this time. So the only thing to remember which can confuse you is, in Heller's cardiomyotomy we don't cut the mucosa or we don't touch the mucosa. In per oral endoscopic myotomy we don't touch the serosa because there is a risk of perforation. We need to consider all of the complications together. All right, I hope it is clear now. If not, let me know in the comments. And what are some other motility disorders? This is nutcrackers, which we talked in the introduction part of mobility disorders as well. That this is the most common hypermotility disorder, which they named it nutcracker, and which is also known as Zachmer's esophagus. So the problem here is that the pressure is very severely high here, which is more than 8000 mm of Hg. So this is too much problem for us. The only thing we need to know is uh, the nutcracker or Zachmer's, the in the nutcracker or Zachmer's esophagus, the pressure is very high, and this is how the esophagus is gonna look like. That's why they call it the corkscrew esophagus. Understood that, I hope. And there is too much spasm as well. This is also we need to know that there is a diffuse esophageal spasm. We say that this is more than 450 mm of Hg, 450 mm, and they call it corkscrew esophagus. So this is very easy to understand on the x-ray, that whenever there is a corkscrew esophagus, first of all what you need to remember is the pressure is so high, which can go up to more than 8000 of mmHg, and you will easily be able to understand that this is corkscrew esophagus by seeing the pattern of itself. So this is it with this video. I hope you understood all of the things very properly. If there is something, please let me know in the comments, and we will cover the GERD in next video because the video was getting longer. I know you are somehow not going to see the videos if it is longer, so just to make it easier for you, I kept only two things in this video, and very soon I'm gonna cover the next video as well for you, in which we will be covering GERD and so on about the esophagus. So stay tuned for the next video. Let me know in the comments if there is something, and have a good night.